Hi, let us now learn about anemia management guidelines in chronic kidney disease. In CKD patients, anemia management follows a structured protocol starting with diagnosis like checking complete blood count, reticulocyte count, ferritin, T saturation, B12, folate, identifying reversible causes, correcting iron deficiency, and then initiating specific therapies like ESAs if needed. Earlier guidelines focused mainly on hemoglobin correction using ESAs. However, newer guidelines emphasize a more conservative HB target, careful ESA use, and stronger focus on iron optimization and safety outcomes like cardiovascular risk. It clarified universal hemoglobin initiation and ceiling targets. Frequency depends on CKD stage and therapy, but typically every 3 months in active treatment. In stage 3 annually, in stage 4 twice a year, and in stage 5G or G5D once every 3 months. At baseline, we evaluate hemoglobin, ferritin, TSAT, B12, folate, and renal function. This helps confirm anemia and identify correctable causes early. Hemoglobin in male less than 13 and in female less than 12 is anemia and severe deficiency, where ferritin less than 45, then C for blood loss evaluation. Before labeling anemia as CKD-related, we must rule out other causes such as iron deficiency, malignancy, or nutritional deficiencies. Iron therapy is initiated when TSAT is low, generally below 30%, and ferritin is below recommended thresholds. In hemodialysis patients, initiate iron if ferritin is less than 500 and T saturation is less than 30. In non-dialysis or CKD, G5PD initiate if ferritin is less than 100 and T saturation is less than 40. Withhold iron therapy when ferritin is more than 700 or T saturation is more than 40. Oral iron is simple but often poorly absorbed in CKD and causes GI side effects. IV iron is more effective, especially in advanced CKD or dialysis patients, and allows rapid replenishment. For example, 1,000 milligrams IV iron can be administered over 15-20 minutes. The target hemoglobin is typically 10 to 11.5 gdl. We avoid normalizing hemoglobin completely due to increased risk of stroke and cardiovascular events. Main therapies include iron supplementation, erythropoiesis-stimulating agents, and newer agents like HIF stabilizers. ESA therapy is initiated when hemoglobin falls below 10 gdl after iron correction. ESAs can be given intravenously or subcutaneously. Dose adjustments should be gradual and not more frequent than once every 4 weeks. Hemoglobin should not rise more than 1 gdl over 2 to 4 weeks. If needed, ESA dose can be reduced by 25 to 50%. When patients do not respond to ESA therapy, first, identifying and treating reversible causes. If anemia is mild or asymptomatic, right arrow, continue monitoring. If symptomatic, consider a 3-4 month trial of oral therapy. If still no response, right arrow, consider red blood cell transfusion. Common causes of hyperresponsiveness include iron deficiency, inflammation, infection, or poor compliance. And these must be corrected first. So remember the algorithm. Diagnose, right arrow, rule out causes. Correct iron, right arrow, start ESA. If needed, right arrow, monitor, adjust therapy. This stepwise approach ensures safe and effective management. Thank you. Stay tuned for more concepts and clinical updates.